Good morning, Hudson. Hi, guys. Doctors. Hello.
It's 8:05 in Bolivia, I guess, no?
Yes, 8-5.
Okay. So, Dr. Lam, please go ahead with your lecture and let's start the meeting.
Okay. So thank you, Hudson. And well, thank you for the invitations to participate. And it's been the fourth session that I've joined, and I've seen it change over the last few times already. It now become very international. And you asked me to give a presentation on the taking the right decision into vitreoretinal surgery. And I thought of this topic is not easy at all to discuss. And first of all, what do you mean by making the right decisions? And what is the right decisions? In life, as in surgery, one is constantly making decisions. From the minute you have the patient in the operating room, you're making decisions. Some decisions are important and some are less important. So how do we make decisions? We make decisions from lessons we learned from the past, from books, from classroom, from colleagues, from teachers. Some decisions are made on the spot without the benefit of the past experience. Indeed, I'm sure some decisions are very creative and innovative at the time. There are many examples of this kind of surgical decision making, like skull buckle versus vitrectomy. When do you do them? What's the best option for the patients? But you can't make that decision unless you're good at doing both skull buckle and vitrectomy. Otherwise, you're biased towards one or the other. Although you do make good decisions, because if you're good at doing vitrectomy, then you should be making the vitrectomy as the decisions. But if you're good at buckle, then you do have an options. And other decisions like oil versus gas, that seems to be a simple one. We usually make that decision very well. But what about case of optic nerve coloboma with the worry that the silicone oil can get into the subretinal space? So this will counterbalance to the concern about having a child able to keep the face down though. Another kind of decision making is phaco versus extra cap. That many things else, that's easy, there's a past discussion. Phaco is thought to be the right decision for cataract surgery these days anyway. But in some circumstances, extra cap is actually a good option for reasons such as cost, equipment, etc. Pan-retinal laser photocoagulation versus anti-VEGF. We have the result of the protocol S, but even with the scientific evidence, many still are debating this option, which is best for the patients still. There doesn't seem to be a clear answer to this kind of decision making. And that's probably the reason why this is probably one of the popular events in the conference where there's debate of those topics I just mentioned. Even when the majority agrees, as in life now, let's say COVID-19, the best scientific decision is face masking. In many of the Asian countries, such as Korea, Japan, Singapore, and Hong Kong, universal face masking were practiced early in the pandemic. And some country now is making it mandatory in the public area. But it's still hotly debated in other countries. The reason is life. There are freedom of choices. Too many government impositions are some of the reasons why some refuse to wear face masks. So in VR surgery, macular hole surgery is probably a very good example. Thanks to Kelly and Wendell, who first showed us it is possible to close the macular hole by creating a posterior vitreous detachment. Subsequently, there has been some debate on to peel or not to peel the internal limiting membrane. Although that debate probably has mostly settled, and most people now has agreed that it is important to peel the internal limiting membrane to ensure higher closure rate of the macular hole. The next question is how? Complete removal of the internal limiting membrane, that's what we do at the beginning, or the inverted flap technique, which is now the more popular choices, or multiple flap technique. If you don't have the flap, you can insert lens capsule or amniotic membrane, or creating a localized macular detachment to free the macular hole from its attachment to the RPE. or relaxing retinectomy for the same kind of reason. And the latest is the autologous retinal transplantations. Some people say when there are many options, that means we actually don't quite understand the exact mechanism and the right choices has not been found yet. At the end, I think we use our own past experiences, lesson learned from our teachers, senior colleagues, mentors, books, and together with lesson learned from conferences and expert meeting like the one that we are having now, added to our understanding, our own understanding of the pathophysiology and the mechanism, that make into your own decisions of what to do and how to apply that to our patients. So I would like to take this opportunity to congratulate to the success of this Retinawesome meeting and to Hassan in organizing this meeting. As I mentioned, from the very first meeting where most of the participants are local experts, now expanded to a panel of international experts from North America, from Europe, from Saudi Arabia, from the extent of the Americans. So I'm looking forward to all the exciting surgical videos and discussion and use the lesson learned to help me, myself, to make the right decision in my next vitreoretinal surgery. So I would like to end by showing two videos. One video is to kind of lesson from the past, and one is what I will use that experience to help my present surgery. So can I share the videos? Sorry, share the screen? Oh, good. So here we go. And
this video illustrates the importance of removing residual cortical vitreous in the surgical repair of macular holes. For vitrectomy to create a posterior vitreous detachment, Retinalog is often used to visualize the vitreous. Once the posterior vitreous detachment has been created, there is still some persisting cortical vitreous attached to the macula. The residual cortical vitreous is often tenacious and highly adherent. We use a Tanno diamond dusted scraper to remove it. Posterior vitreous detachment. Here we present another case of posterior vitreous detachment. The posterior vitreous is separated with aspiration. Retinalog has been added to help visualize the residual cortical vitreous. The vitreous, again, is very tenacious, but can be removed using intraocular forceps. The cortical vitreous behaves more like chewing gum stuck on wet tissue paper than like a membrane.
so this video was made in 2008. So the surgery still was done with 20 gauge instrument. And at the time, I thought it was interesting kind of observations that
once all the residual cortical vitreous has been removed, the internal limiting membrane can be peeled. You can see that the ILM has a completely different consistency as the cortical vitreous. It peels much more like a membrane.
So the presence of the vitreous actually prevent adequate peeling of the IOL. And at the time, we don't use dye as we're using now. And so the cortical vitreous as well as the membrane.
Removal of residual cortical vitreous and subsequent stripping of the internal limiting membrane are essential steps in the successful closure of a full thickness macular hole.
So we're using the catalog to help to do the surgery at that time. But the crucial lesson I learned was that the importance of using the recognizing the posterior vitreous cortex. So I want to share the next video, and let's see. Can you? Oh, did I get out?
No. You're still there, doctor.
Oh, okay. Can I share again on the video? Yeah, we go. Good. All right. So so now it's a case of macular hole with a total retinal detachment. You can see at the beginning of the case, when I was doing the vitrectomy, the subretinal fluid was drained through the macula. And then
אני מכבה את האורות.
so you can see the subretinal fluid actually get drained, and I was looking in the periphery to make sure there's no retinal detachment or retinal tear that's there. And when I tried to peel the posterior cortical vitreous, you can see the retina being very mobile was difficult to do, and it get elevated. So I decided to use a bimanual method using the forceps and the diamond dusted membrane to first peel off the vitreous, then to peel off the internal limiting membrane. And you can see with just the forceps alone, the retina get lifted away because of the retinal detachment. But using the bimanual method, using the diamond dusted membrane scraper and the forceps, I can strip off both the vitreous, posterior cortical vitreous, as well as the internal limiting membrane, despite the fact that you have a mobile detached retina. You can see a large sheet that stained internal limit membrane was peeled off from the retinal surface around the macular hole. This will ensure the hole to close with the reattachments of the retina. Then next is the decisions to do air-fuel exchange. And I realized the hole itself is quite small, even though there was some drainage at the beginning of the vitrectomy through the hole. I really did not want to enlarge the macular hole. And so I did not want to drain through the hole itself. So you see during the drainage, I decided to drain in an extramacular positions. And this way, I would not be running the risk of enlarging the retinal hole. And you can see there's a small retinal break that was created, and then the drainage was done there. So this way, the retina get reattached without having the risk of enlarging the macular hole if I drain through the hole. So I think these two videos illustrate the importance of recognizing the presence of residual cortical vitreous despite a posterior vitreous detachment. If you don't take care of that, it will not allow you to drain the retinal detachment properly. And to do the surgery for the macular hole detachment, a bimanual approach works much better than the forceps try to peel off the membrane when you have such a mobile retina. So I think the choice of making the bimanual approach has made the surgery easier and able to complete that. And lastly, the extrafoveal drainage site allowed a complete drainage of subretinal fluid without the risk of enlarging the macular hole. So those are kind of decisions that was made during the procedures. Whether they are right or not, fortunately, the outcome speak for itself, that it allows the patients to have a successful outcome and reattaching the retina without the presence of the macular hole.
Thank you very much, Dr. Lam. It was a pleasure to see your videos, and it's very good that you can share your experience with us.
Dr. Lam, how do you like using the chandelier for bimanual surgery? When did you start using the chandelier? I feel very comfortable, not using it, but oftentimes we have to use, because the instruments got a lot better nowadays. You have better instruments. We don't have to use that too much scissors for removing the attachments from the vascular membranes in diabetic retinopathy, for example. But still, chandelier is something that came to stay. And when did you start to use, and how often you use?
So I usually use the chandelier for the diabetic tractional retinal detachment, especially those very stubborn cases with atrophic retina. I found that it minimized the risk of creating retinal breaks during the surgery, and it allows a more intended or more careful dissections. And so that has been the main reason for me to use the chandelier. And sometimes I use it because I don't have an assistant in the room, and I needed to do good peripheral indentations to do peripheral vitreous space trimming or removal of the peripheral vitreous. And I found that is also helpful. And I just show you a case that it is very beneficial to have that two instrument, because otherwise that mobile retina makes it very difficult to complete the task of peeling off the residual cortical vitreous and the very adherent internal lymphing membrane. So I think that the lighter instrument has helped to reduce the need for some of those maneuver, but the chandelier does give you more options and flexibilities.
Yeah.
Dr. Lucan, do you want to comment?
I just want to ask why haven't you used PFCL during that procedure, during the peeling and then during the drainage? Because with PFCL, you can drain from a peripheral break, not from a drainage retinotomy near the optic nerve.
You're right. And as you saw in the video, I start off the surgery actually looking at the periphery to see if there's any peripheral retinal breaks, and there wasn't any peripheral retinal breaks. So, so that means I will have to create a peripheral retinal breaks and then to use the PFCL. In addition, I will have to peel the posterior cortical vitreous and the internal lymph membrane under the PFCL. Yes, it can be done, and I think it would be easier to do it without having the PFCL to peel off those, particularly the posterior cortical vitreous, because they are quite adherent and they are not easy to grasp. And so that's part of the reason why I make the decisions not to use the PFCL in this case.
I can make a quick comment and question. Dr. Lam, thank you so much for your talk. And regarding the controversies that you introduced your segment with, it reminded me of a saying that my mentor, George Williams, often tells us. And he often says that good judgment comes from experience, but experience comes from bad judgment. But thankfully, the experience we can gain from talks like yours and this webinar that Hudson has organized. And so I think it really makes all of us better. And I think your video with the technique with the counter traction with the Tano scraper is fantastic, something I haven't done, but I will next time. I have a question. I'm very curious. So in 2008, peeling ILM routinely for macular hole, it wasn't something that was vogue. We do it very routinely now. But I was curious what your inspiration was for you to pursue that very, at the time, novel concept.
I think there's actually been some discussions about peeling IOM, and the difficulty, the challenge was that to peel it consistently, because we didn't have the benefit of those vital dye. We didn't have trypan blue, we didn't have ICG. And we first start peeling even without the catalog. It was by kind of chance. Some people and myself also observed the opportunity that the triamcinolone do stain or adherent to the IOM. And but at the time we are not often sure we complete the peeling of the IOM, and so it was not something that was consistently done. So it was not able to show its real benefit. So I think at the time I was bought into the fact that it makes sense to peel, and that's why that was what's been shown. Incidentally, just for the record, that was a 2008 entry to the ASRS Film Festival, and that's why the date was it's not by fluke or by making up. So it was 2008.
Great, thank you.
Waiching, hi. Correct me if I'm mistaken. I was the fellow 2007-2008, and as I remember, we peeled the ILM in any macular holes we did.
Yes.
So, yes.
Thank
so
you.
we were peeling. No, thank you. So we were peeling ILM 2007-2008, and as far as I remember, we were rejecting ICG. Yes.
And I think ICG was not as popular, but catalog was used more at the beginning. Yes. And also, incidentally, now that I'm in Hong Kong, there was publications on the concern about use of ICG toxicities for the exposed RPE in the macular hole. So I think now that I'm in Hong Kong, I don't have access to ICG at all because they forbid me to use it. Even though I'm so used to use ICG in Toronto, I have to learn to use trypan blue as an alternative to use the dye. At the beginning, I found it hard to see the IOM, but now I'm getting used to it.
Thank you very much, Dr. Lam.